Thanks very much. Thanks for the introduction. Thanks to Sal, Christian, and Alex, and Valeria for inviting me and their great organization as well. We're going to spend a little bit of time talking about urinary sodium, a little bit of a pivot in topics, but I think this may be a cheap and very effective way to measure our response to therapies. We talk about natriuretic peptides and urine output and weight change and diuresis, etc. But I'm hoping after this talk you'll have some liking for considering urinary sodium as a measure of diuretic responsiveness. So we're going to talk about its historical use, which is identifying diuretic responsiveness, and also prognostic utility. You see that net negative sodium during hospitalization is a strong prognostic indicator, a good one. The current recommendations for urine sodium, which are actually quite surprising, and I would suggest the missing pieces are some randomized data. So urine sodium identifies poor diuresis. Spot urine sodium about 2 hours after diuretic is highly predictive of subsequent natriuresis and diuresis. If urine sodium increases, water will follow it, diuresis follows it, decongestion occurs. There's actually extensive data about this. This is just a snapshot from a recent manuscript, but you can see over the last decade several trials all looking at spot urine sodium, many different kinds of outcomes, natriuretic response, cardiovascular outcomes, etc. I highlight one column because I think this is the problem, right? These are a lot of retrospective studies based on prior data. No one has really conducted a randomized or blinded trial looking at if I use urine sodium to drive my therapy, to drive my furosemide dosing, is it better than what clinicians do currently? And I think that's the big unanswered question. How about prognostic value of urine sodium? It's actually quite prognostic. Total sodium balance. Now, granted, this is hard to do. It's hard to measure urinary sodium in the hospital, but in those studies that have done this, total sodium balance is much more prognostic than weight loss, ins and outs, urine output. It's likely because, as we know, the documentation of I's and O's urine output is very challenging, right? Mrs. Jones goes in the toilet, doesn't measure it, flushes it. Mr. Jones goes in the urinal spills. It's just documented as urine output, but we don't know what the quantity was. So very hard to keep good measures of that with 1:4 and 1:6 nursing ratios. So how about natriuretic response and survival? So Jeff Testani is really the pioneer of urine sodium, and they looked at this subset of patients from the ROSE heart failure trial. So 360 patients with acute heart failure were enrolled. All received very high dose loop diuretics following the dose protocol, so 2.5 times their home dose IV. Sodium excretion was actually measured very controlled, as it can only be done probably in a clinical trial. They measured each 24-hour period of urine sodium excretion for 3 days. They analyzed 316 patients, so a subset with complete data for the first 24 hours. We defined a positive sodium balance as when your sodium excreted is less than your dietary intake. So roughly these patients were on 2-gram sodium diets. They measured sodium for 24 hours, and if you peed out less than 2 grams, you had a positive sodium balance. Conversely, the more net negative you were, if you peed out 3 grams of sodium, as you'll see here, that's considered to be a negative sodium balance, which is the most important finding of the study. They looked at 6-month all-cause mortality. 2 figures here. First one just showing negative in sodium balance. So I peed out more sodium than I ate. I didn't pee out more sodium than I ate. Big difference in survival. And I put this second figure up to show you that, again, the fluid loss parameter just doesn't matter. It's too hard to correlate. This was in a clinical trial at many good centers, right? So fluid loss, net negative I's and O's over the same time period with a positive sodium balance, it was still prognostically poor. Okay, it tells you that this parameter is not very well quantified probably, but those with a net negative balance, again, much better outcomes. So it's interesting if you look at the guideline recommendations for use of urine sodium. This is a position paper. Many of the people in the audience are actually on this paper. And I like it because it actually puts right in the middle here. Someone comes in with acute heart failure, gets a dose of diuretic. I quantify their urine sodium or their urine output, and I redose them based on this. If they don't have a good urine output or greater than 50 to 70 milliequivalents per liter, so this is a spot measurement, right, of urine sodium, I actually double their dose of diuretic. So this suggests that this parameter, urine sodium, may be just as good as urine output, and I would argue that it's an easier thing to measure. Are they peeing 150 cc's an hour over 2 hours? This requires a quantity versus I take any drop of sodium, I pull a little sample out of their urine, pull a little sample out, send it to the lab, measure their sodium. Much easier. I don't care if they peed 1 liter or 2 liters. I want to know what their sodium. Initial diuretic, after 2 hours, spot urine sodium, there's that number of 50 to 70 again, right? If you're not peeing out a lot of sodium, the answer is no, double the dose of loop diuretic. So it's in a position statement, it's in the guidelines from 2021, despite there being no randomized data with this. So I would suggest why guideline support, because everything else is quite horrible, right? Urine output, I's and O's, weight change, all really challenging. Someone is net negative 3 liters of urine and they've gained 4 pounds. This makes no sense whatsoever. That's a lot of food they're eating, or one of those two is really inaccurate, right? However, and diuretic resistance from diuretics is obviously not detected till 24 to 48 hours after it began. You don't realize they're getting worse until they've gotten worse. And I think that's where urine sodium will win. It quantifies output initially, and it shows you when they have diuretic breaking. They're peeing out a bunch of sodium, they're above 100 milliequivalents per liter, and all of a sudden it drops to 20. Something else is going on, they need to have their diuretics up-titrated. So spot urine sodium really helps us define forward movement and speed from a diuretic efficiency perspective. The big question is, can urine sodium be used to guide diuresis? Okay, well, Jeff Testani put this on the map. It's almost a decade ago now. He published this Sentinel article, and this is where all of this data in the guidelines is coming from. What he has shown in his data is that this is highly really good data collection, tight urine collection over a 6-hour time period. But he got a spot urine sodium 2 hours in, and that ability of that 2-hour urine sodium to predict 6 hours total urine sodium, look at that R, 0.91, very high. He also found that in patients, many of these patients had Foley catheters in, this spot urine sodium was highly predictive of 6 hours diuresis as well. So a spot urine sodium predicts 6-hour natriuresis and predicts 6-hour diuresis, okay? So he's onto something here, and he went and validated this in a large sample of patients. So kind of a complicated paper, but he used his diuretic titration protocol based on urine sodium and said, I'm gonna up-titrate diuretics if people aren't putting enough sodium out. And I'm gonna measure this using this prediction equation he has. Again, spot urine sodium for predicting at 6 hours how much urine sodium they're going to put out. Look at those areas under the curve. Really hard to find other test characteristics that are that high. So what he's saying is it doesn't matter whether you pee out a little or a lot, I'm going to be able to identify it with this prediction equation based on a 2-hour spot urine sodium. Okay, one sample 2 hours after the diuretic's done tells you how they're going to do over the subsequent 6 hours. And what happened when he used this formula in the hospital, this is real data. So this is prior to using his formula. You can see peak loop diuretic dosing gets ratcheted up in a major way, and that's not a typo. That's 500 milligrams of furosemide per dose, 3 times a day. So major increases in diuretic, major increases in urine output, major net negative changes, and guess what? Real weight changes as well. Okay, so now he's operationalized this, and this is how it works. Mr. Smith gets a dose of diuretics. 2 hours later, I check a spot urine sample for urine sodium and creatinine in his formula. It goes into this online calculator, which is available online, and it tells you how much total sodium they're going to put out and what your next dose of diuretic should be. And that's how he used this in this real-world example. And then, voila, your diuretics go up a lot. So what happened in his situation? Well, this is the total patients, and 84% of them got discharged, euvolemic, decision to add a thiazide. So the clinicians were getting this data back saying, your patient's either peeing out a lot or not peeing out a lot. And you can see a fair number of patients actually transitioned to a standing order of 500 TID of furosemide. And if you talk to Jeff about this data, what this equation is telling you is that you need to up-titrate your diuretics faster to get to an optimal dose, and when they break and diuretic break again, you need to up-titrate again and overcome the diuretic breaking. And that's how this formula has won. So I think it's compelling preliminary data, But what the next steps are, we have no randomized data. It's in the guideline, it's in a position paper. No randomized data whatsoever. We just started a randomized trial, got funded by NIH, looking at this exact thing. So we randomize patients to what's happened currently. The heart failure team sees the patient, puts them on 120 BID of Lasix for 24 hours. We start measuring their urine, and we titrate. If they get in one group, 120 BID is what they get. If they get in the intervention group, we start ratcheting up their diuretics quickly. The maximum dose in the intervention group is 500 milligrams of furosemide and 500 milligrams of thiazide, chlorothiazide. So big doses these patients can get to very, very quickly. We stop for important things, symptomatic hypotension, they get decongested and go home. They have a significant bump in their creatinine that the team doesn't want to keep diuresing. Remember, we expect almost everybody to bump their creatinine. In fact, that's a positive prognostic sign when your creatinine goes up during diuresis, because you're probably actually decongesting them. And then our primary outcome is net clinical benefit, which is a combination of symptoms and days on IV diuretics. The whole goal of this is to be efficient as possible, get people off diuretics, transition to PO diuretics, symptoms improved, and not come back to the hospital and get readmitted. Kevin Dahmen and colleagues are doing this right now in the Netherlands. They're about 2 years ahead of us. Their data will probably be out in the next year or so. They look at a little different strategy than we do, but again, randomized, not blinded, usual care versus natriuretic guided treatment. They only go for a couple of days. We go till the end of therapy. Their co-primary endpoint is 24-hour natriuresis, so 24 hours of urinary sodium, and then 6-month all-cause mortality. So quite a ways out. So the main differences in our trial is called Escalate. PUSH-HF is Dahmen's trial. They are using a dichotomous cut point. If your urine sodium is less than 70, we're using Jeff's equation, which is a little more complicated. It requires a sodium and a creatinine and a calculator, but it's not overly complicated that it can't be used in real time. They don't blind, we do. They transition at 36 hours. We've had patients on our protocol for 10 days, so we go until they're off diuresis. Their max is 5 of Bumex, ours is 500 of Lasix plus the thiazide. And a little bit different endpoints, but I would say these trials are gonna be complementary. I mean, really, Kevin and his team are gonna answer a lot of good questions about natriuresis and long-term outcomes and practicality of implementation, and our trial is gonna be blinded and looking at a little bit longer course of therapy, but I think very complementary. So in summary, I think urine sodium does quantify response to diuretics. It's associated with better outcomes, especially when you have net negative sodium overall during your hospitalization, and it's to a much greater degree than other measures of diuretic response, urine output, weight change, et cetera. But the real question to be answered, and that hopefully we'll have answers soon, is does a diuretic strategy that targets driving up your urinary sodium as part of the intervention arm really make a difference in your outcomes? Efficient time on IV diuretics, symptoms, readmission, mortality, et cetera. Hopefully we'll have an answer soon. That's it. Thank you.
Any questions? Christian?
Congratulations for putting diuretics again on the center stage, because I think from my perspective they are one of the most underappreciated drugs in cardiovascular care, and I think their benefit in acute heart failure is so obvious, and still some ignorant theoretics argue we should do randomized trials with and without diuretics. Could you comment on how you have chosen the standard of care for your intervention study? Because ultimately, of course, your study will be judged whether the standard of care is really as good as it gets. Now, if I understood it correctly, you use a fixed dose to start with, which is different from what currently guidelines recommend to choose the initial diuretic dose.
So, great question. You're right, because if you compare it to a straw man, your intervention always wins, right? So, I probably misspoke. Usual care is 2 times their home dose of IV diuretic to start with, and then they get that dose open label. Everybody knows that they get 120 to start with. And then what happens is since I'm blinded, I actually order 2 doses. I order what the clinical team wants, which after 120, maybe 120 twice a day, and then what the calculator says they need based on urinary sodium. So our heart failure teams follow the dose strategies, but they actually titrate up fairly aggressively beyond the dose strategies if needed. But you're right, the table 1 comparison of doses of diuretics may be dramatically different because of that, because it's physician dependent, but we strongly encourage dose guiding diuretics.
Thank you, Sean. Nice to see that you have this randomized trial coming, and I have 2 questions. What would you advise the colleagues who are seeing patients with hyponatremia already in the beginning? So what will happen to plasma sodium when you do this aggressive, let's say, anti-sodemic treatment? And secondly, what were your tools of assessing the decongestion? Ultrasound of IVC, natriuretic peptides? Please tell me.
You hit on the crux of this study, Veli-Pekka, which is like volume assessment, right? So the volume assessment is really, every day we round with a team, it's GVP, it's their weight loss, it's their leg edema, it's their symptoms, and their net negative I's and O's. It's the old school versions. They do get an echo with IVC collapsibility up front, and ascites and those sort of thing measurements, but it's not done serially. So that's a challenge. I mean, we've been treating patients with a cheap medication for decades, and we still don't know how to titrate it, but it's limited a lot based on, should we be using ultrasound of the internal jugular vein? I think we probably should, but we don't currently. Your first question was about sodium. If it's hypervolemic hyponatremia, which a majority of these patients are, their sodium should get better as you diurese them. However, we have a cut point of 125 serum sodium that you can't get into the trial. If you're lower than that, something else could be going on, and there's definitely a risk that we make him more hyponatremic. Yeah.
Here are the next questions.
How much the sodium add to the diuresis? Because usually after 1 hour, if you see a patient has 100 milliliters of diuresis, sodium is not really, doesn't add anything. Which is the proportion of patients that you think that really sodium is giving the clue that is not responding appropriately?
So how much is that really impacting their diuresis? Yeah, I mean, anecdotally, a lot of people have good urine output and good sodium output early on, and then it's 24 hours in where their sodium really drops off, and that's where it's probably the most helpful, is when they start to break. I should say also, as we did this, we were really careful with how much sodium we gave them, because the blinded bag of diuretic is 100 cc's every 6 hours. It could be a lot of volume, so we give it in D5W for that reason, that we don't want to give them more sodium.
Sean, thank you very much. My question is that many of the heart failure patients are totally volume overloaded. A subset are actually have volume that's redistributed because of vascular resistance. We saw that in all the monitoring we did. And the therapy seems to be very different in both those. The first one, you need to get rid of water. The second one, you need to vasodilate, and they'll get rid of the water. Does this help you in any way discriminating those 2 types of people?
No, that's a great question. So Richard's talking about the typical HFpEF patient with hypertension and volume redistribution from splanchnic nerve or splanchnic venous sequestration versus the HFrEF patient who's 15 pounds up and has a lot of extravascular volume. And for that reason, so this doesn't help you. In fact, you could get into trouble if you had a patient who had volume redistribution, wasn't total body fluid overloaded, and started targeting them with urine sodium. You'll pull it off really quickly, and they'll become intravascularly dry. So to get into our study, they have to be 10 pounds above their dry weight, or a physician estimate of at least 10 pounds of volume for that reason. Ideally, we want to have some to be extravascular and some to be intravascular, so we can take off their intravascular component, they can remobilize the stuff from their legs, and we can continue to diurese them. The HFpEF patient with hypertension would be a problem, and we try to avoid those with that 10-pound discrepancy to get in.
Could you comment on a low sodium diet while in hospital? As you know, there's an overlap between malnutrition and heart failure and the problem of congestion. And just to position myself, I hate low sodium diet. I was successful getting it rid out of the hospital, and I'd like to know whether this was a good thing or you think is a bad thing.
I think most U.S. patients side with you, Christian, and don't like low sodium diets either. So we put them on a 2-gram restricted sodium diet, keeping them on that when I walk in the room and there's like cupcakes at the bedside and stuff like that. That's a little challenging, right? In fact, I think that's why the low sodium diet that was just published, right, from European data, looked like it didn't work. However, low sodium diet in the U.S. is probably 5 to 6 to 7 grams of sodium when they're out of the hospital. So it's a challenge to keep them on it. And that's the delta we're looking at, though, because if we let them go to 4 grams of sodium, then our diuretic goals are much different. So it's a challenge. I know it's not a fun diet, but we have to keep them a little lower than usual.
I have a question.
Yeah.
In both of your arms, do you have a water restriction? How much they're allowed to drink?
Yes.
What is it?
I'd have to look again because somebody crossed it the other day. I think it is 1,500. It's 1 liter, 1,000 cc's per day. I'd have to look again to be sure. But there is a water restriction because one of them who wasn't on it drank 2.5 liters a couple of days, and so yes, it's a big deal.
Okay, and my second question is, do you really, because of course we know that we should treat heart failure using diuretics, but do you really think that we can maybe guide our therapy using spot urine instead of biomarkers? Because that is definitely where we're going, right?
Yeah,
using biomarkers.
I think it's much more dynamic, and all the preliminary data really suggests. I mean, it's in the guidelines already that it will be dynamic enough to follow. You know, some of our secondary endpoints are differences in natriuretic peptides between admission and discharge for that reason. But that has been looked at so extensively and so challenging with diurnal variation that daily measurements of peptides are probably not going to be the answer. I'm hoping it's urine sodium.
And maybe whatever you find in your study, this would be something that could be implemented in developing countries where biomarkers are not available.
Correct. I mean, I think lung ultrasound and urinary sodium, right, it's very portable, these butterfly devices for lung ultrasound. And urine sodium, it's a test you can do at the bedside almost. So, you know, it's like $6, you know, a few euros to do. Yeah.
Thank you very much.